is my video presentation number 2. So the patient was a 70-year-old male that presented to the ED on 9/2 with symptoms of purulent drainage, pain, and erythema from his right knee amputation site. The patient was noted to have a right BKA on 7/16 due to severe PVD with admission to a SNF following. He noted that days prior to the admission, patient had tenderness and gradually worsening erythema to his BKA site. Upon admission, patient was placed on a broad-spectrum IV antibiotic, vancomycin and Zosyn. But due to CKD, patient was put on linezolid and cephalosporin. Patient had culture and sensitivity done that was found to have MRSA inside the wound. Patient was evaluated by vascular therapy for PVD, but pain was attributed to muscle spasms rather than vessel occlusion. After evaluation by the surgery team, there is a possibility for an above-knee amputation in days to follow, but at this time he has not had that done. Patient has been improving with assistance of antibiotics. There is a significant amount of necrotic tissue still residing within the wound. At this time, his white blood cell count has been steadily improving and dropping, and his kidney function has also been steadily improving. Moving on, now we have his assessment. So generally, patient is having generalized weakness. He is pleasantly confused, and he does have a resting tremor at baseline. Upon assessing of his cardiac system, S1 and S2 were noted without any murmurs, rubs, or gallops. Respiratory system, patient had mild wheezing with expiration and occasional productive cough, but no signs of respiratory distress. Upon listening to the abdominal sounds, patient has bowel sounds noted in all 4 quadrants, and his last bowel movement was the day prior to examination. His GU, patient has decreased urinary output, most likely due to dehydration. He did have a Foley catheter in place with no discharge noted from the catheter and is draining normal colored urine. His muscular system was unable to be assessed due to his BKA and ambulatory restrictions, and as well as integumentary system. So everywhere but the wound, the patient's skin was pink and dry, but in regards to the wound, it was in the right medial aspect of the amputation site. The wound is a red beefy color with copious amounts of clear drainage. Patient did have a large amount of necrotic tissue still located within the wound. Moving on. Financial and advocacy. So the patient has been in the hospital multiple times over the last month and has acquired quite a large hospital bill. His last hospital stay starting 9/2, his hospital bill is currently at $85,000. Although the patient's hospital bill is significant, patient is on a full coverage Medicare plan. So all inpatient hospital stays are completely covered, so the patient will not need any financial assistance at this time. Advocating for this patient is crucial. This patient has severe PVD that can be a result of various dangerous life choices. Advocating for this patient would include vast amounts of education. The patient is a former tobacco smoker, but as of now does not use tobacco anymore, but he is a current alcohol user. Patient has comorbidities of hypertension and hyperlipidemia. Educating the patient on the risks of drinking alcohol in large amounts daily is as a vasoconstrictor, subsequently worsening his PVD. Patient's comorbidities also are vasoconstrictors, so educating the patient on the importance of taking his antihypertensives and antiplatelets daily to decrease any further complications. Moving on, we are going to talk about the top priorities and prioritizations and some supporting cues. For the patient with PVD, MRSA, and a right below knee amputation, the top priority is by far infection control. The patient does have MRSA, which is a methicillin-resistant Staphylococcus aureus, a serious infection that can lead to various systemic complications, including sepsis and slow wound healing. So positive MRSA culture was the cue for, as well as redness, warmth, and increased pain. He did have a fever, chills, and increasingly climbing white blood cell count. And there was localized and systemic signs of infection, including that erythema and drainage. Some other top priorities for this patient would be impaired circulation and wound healing, risk for skin breakdown, pain management, and functional mobility and prosthetic fitting if he was able to get a prosthetic leg. Some goals for this patient is by far, again, infection control. The desired outcome, the MRSA infection will be effectively managed, preventing any systemic infection and promoting wound healing. Goals for this patient would be to decrease any signs of infection, which at this time were decreasing. The wound culture would show no further bacteria growth by the end of the antibiotic course. The patient will adhere to the infection control measures such as hand hygiene and wound care during hospitalization. During my care for the patient, we did change his wound 2 times, as evidenced by proper wound dressing technique. The patient has at this time remained afebrile and normal vital signs throughout the hospital stay. And moving on twice. One more time. So infection control, MRSA for the nursing intervention would just be infection control, especially of his MRSA. He is currently on contact precautions, so everyone that comes in and out of the room does have to be in full PPE. You also would want to monitor for signs and symptoms of infection. So at this time, his fever had gone down. He is still having signs of redness and drainage to the wound site, and just to report any further conditions to the healthcare provider. Patient is on antibiotics that are MRSA targeting, and monitor for signs of nephrotoxicity and allergic reactions to these antibiotics, which at this time he is not experiencing. We would also want to implement strict contact precautions. As I said before, anyone that goes into and out of the room needs to have proper hand hygiene and infection prevention measures. Wound care was performed using sterile technique and monitoring lab results, and as I said, at this time, those lab results are decreasing. Post-shift, patient is much more pleasant. Suspected sundowning. This patient just noticeably was more irritable in the beginning of the morning and at the evening. He has no history of dementia, but it is just noted that among the nursing staff, there was a pattern noted. We are going to move on twice to the pathophysiology of MRSA. So MRSA is an infection at the amputation site with necrotic tissue. It is a complex process involving both bacterial virulence and host immune response. At the cellular level, MRSA, particularly with necrotic tissue, thrives due to its ability to evade the immune defense. One key mechanism is called biofilm formation, where MRSA clusters into protective layers that shield it from antibiotics and the immune system, allowing it to persist in the wound. MRSA expresses various proteins such as fibronectin binding proteins that enhance its adherence to tissue and invasion of cells, facilitating a deeper tissue colonization. The presence of small colony variants, a slower growing form of MRSA, also contributes to persistence and antibiotic resistance, as these forms are harder to detect and treat. The necrotic tissue itself often results from insufficient blood supply, ischemia, and infection provides an ideal environment for MRSA. The infection leads to release of various toxins, which target and destroy immune cells like neutrophils. In necrotic tissue, the inflammatory response becomes dysregulated. MRSA triggers excessive cytokine release, leading to systemic infection, also known as sepsis, while local immune defenses fail to contain the infection. The combination of the biofilm protection, toxin production, and immune invasion leads to tissue destruction and the spread of the infection to deeper muscle and bones. Surgical debridement, which this patient did go under, often coupled with antibiotics targeting MRSA, remains essential to managing this infection. Moving on. So the next is a encephalopathy, particularly due to a MRSA infection. The brain is affected at multiple cellular levels. The infection triggers a widespread inflammation, releasing cytokines like TNF and IL, which damage the blood-brain barrier. The disruption allows harmful substances to enter the brain, causing what's called neuroinflammation. Cells like microglia become overactive, releasing reactive oxygen species that damage neurons. The result is oxidative stress and impaired mitochondrial function, leading to decreased energy production in neurons and cognitive impairment. Hypoxia worsens the damage, especially to the brain white matter. This disrupts the neural communication, leading to symptoms such as confusion and delirium that this patient was undergoing. Next, we'll be moving on to anemia. So anemia in this patient with MRSA can occur. We're just going to quickly go over this because those were his two main. So anemia can be particularly dangerous in MRSA patients for several reasons. For compromised oxygen delivery, increased cardiovascular strain, impaired immune function, delayed healing, and overall health compromise. Okay, next. So we're going to talk about the clinical manifestations of MRSA and encephalopathy. MRSA, the mechanism at the cellular level is that inflammatory response, so the MRSA infection can lead to the release of those cytokines. The neurotoxins, which is the bacteria themselves, have on them, or the immune response they may produce that directly affect neuron cells, leading to altered mental status and cognitive dysfunction. And the clinical manifestation symptoms of encephalopathy include confusion, altered mental status, and cognitive impairment. These arise due to the disruption of neurofunction and inflammatory effects on the brain. So next is anemia and MRSA patients. Mechanisms at the cellular level is just that in chronic inflammation, MRSA infections can lead to chronic inflammation, which affect iron metabolism, which can lead to MRSA, which can lead to anemia, which is that low iron level. Also, bone marrow suppression and blood loss hemolysis. Symptoms of anemia include fatigue, pallor, and shortness of breath. These were definitely noted within the patient, but he was unable to ambulate, so they might have been suppressed. These results from decreased oxygen carrying capacity of the blood due to low hemoglobin. Next is the pathophysiology of CKD, so his comorbidities. CKD, chronic kidney disease, is a progressive kidney damage, includes glomerular injury, so CKD often starts with the damage of the glomeruli. Conditions like diabetes and hypertension, which the patient had, can cause scarring of the glomeruli, reducing the ability to filter blood. It also includes tubular damage. Tubules that are responsible for reabsorbing nutrients and excreting waste can also be damaged. This can result in impaired reabsorption and essential substances and increased level of waste products in the blood. Also, a decreased glomerular filtration rate. Reduced filtration can occur in CKD patients as well. Why antibiotics are contraindicated or require adjustments in CKD is important just to talk about the fact that he had to switch antibiotics because his kidney function was declining. That just has to do with drug clearance, so many antibiotics are eliminated from the body through the kidneys. In CKD, reduced kidney function can impair the clearance of these drugs and further damage the kidneys. Also, certain antibiotics can cause nephrotoxicity. So if a patient like this patient who has CKD, you wouldn't want to put them on a nephrotoxic antibiotic. Next is peripheral vascular disease and hypertension. I combine these in this slide because they definitely relate. So patient endothelial cell injury leads to inflammation, plaque formation, and arterial narrowing. This reduces blood flow and causes ischemia and tissue damage. And so PVD is the reason that this patient did have to have a right below the knee amputation just because of decreased blood flow. Amputation needs, so gangrene, severe ischemia can cause tissue death, which is the reason the patient had to have an amputation. The patient also had hypertension. High blood pressure damages those endothelial cells, promoting inflammation and vascular remodeling. Increased smooth muscle proliferation and collagen deposition leads to vessel stiffening and further resistance. So again, critical limb ischemia, hypertension can exacerbate PVD, which leading in severe cases will lead to amputation in most patients. So next we're going to talk about treatment and procedural integration. So the patient is being treated with antibiotics for MRSA infection that are safe for kidney infection, safe for kidneys and infection control. Biggest thing for this patient at this point is comfort and palliative care and pain management. And again, if he needs an above knee amputation, we will go ahead and go through with that. Next, we'll talk about his lab values, the important lab values that were either increasing or decreasing. So his white blood cell count when he came to the hospital was 11.3, and by the time I saw him and assessed him, they were at 5.7. So significantly decreased. He did have a low red blood cell count, low hemoglobin, and low hematocrit, which all attributed and were noted in his anemia. And he did have an increased BUN and serum creatinine that have, at this point, decreased since changing the antibiotic. And now that is the end of video presentation number 2. Thank you!